This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the University Hospital of Erlangen, published in Acta Neurochirurgica in 2026. It's titled Giant Pituitary Adenomas, an institutional experience with 289 surgically treated patients.
This is a significant paper, Alara. When we talk about giant pituitary adenomas, or GPAs, we are moving out of the realm of standard pituitary surgery and into some of the most challenging cases a neurosurgeon can face. The Erlangen group, led by names like Binder, Fallbush, and Buchfelder, is reporting on a massive series spanning 40 years.
Exactly. To set the stage for our listeners, they define a giant pituitary adenoma as having a maximum diameter of 4 centimeters or more in at least one plane. This definition actually dates back to the work of Simon and colleagues in the late 70s and early 80s, who noticed a clear difference in complications and outcomes once a tumor crossed that 40-millimeter threshold.
Right. And what makes this study particularly robust is the volume. They looked at 289 consecutive patients who underwent primary surgery between December 1982 and December 2022. That's 289 giants out of a total pool of over 6,100 pituitary patients. That really highlights how rare these are, only about 4 to 5% of their total pituitary volume.
It's a huge cohort for such a specific pathology. Looking at the patient characteristics, there were more men than women, 174 males to 115 females. The mean maximum tumor diameter was 4.6 centimeters, plus or minus 0.7.
Let's dive into the surgical strategies because that is the core of this paper. For a long time, the dogma was that if a tumor is that big, you have to go transcranial. But this paper shows a modern shift. Alara, what did the breakdown look like?
It's quite interesting. Despite the giant status, the transsphenoidal approach, or TSS, was used in the majority of cases. 201 patients, so nearly 70%, underwent TSS only. 36 patients, or about 12%, had a transcranial approach, TCS only. But the real giant management comes in the two-stage strategy.
The combined approach. 18% of their patients, 52 people, had a combination of both within a few weeks.
Exactly. Usually the second surgery was performed within 6 months of the first. The paper mentions that the choice of approach was defined by the size, configuration, and extent of the tumor. They note that while TSS achieved good results, the tumor configuration often required that transcranial component or a combination of both.
For the residents listening, this is a key takeaway. You aren't always looking for a one-and-done hero surgery with these. Sometimes the best way to protect the patient is a planned, staged resection. They also mentioned intraoperative imaging, which they introduced in 1996. It was used in about 22% of these operations.
And we should talk about the why behind these surgeries. Why are we operating on these giants? The paper emphasizes that these tumors aren't just large, they are invasive. They invade the cavernous sinus, the sphenoid sinus, the clevis, and the arachnoid. This determines the resectability as much as the sheer size does.
Let's look at the outcomes. In neurosurgery, we always aim for gross total resection, GTR, but with giant adenomas, but's a tall order. What did the Erlangen group find?
GTR was achieved in only about 1/5 of the patients, specifically 52 patients, or 18%. This really highlights the difficult-to-treat nature of GPAs. The authors explicitly state that GTR was dependent on tumor size and extension. If you have a 5-centimeter tumor wrapping around the internals, GTR might not even be the safe goal.
It's a sobering statistic, but an honest one. In many of these cases, the goal is decompression of the optic apparatus and stabilization of the disease rather than a radiographic cure. Speaking of the optic apparatus, how did the patients do ophthalmologically?
They used a modified score from the German Ophthalmological Society. Preoperatively, almost all these patients have some deficit because of the suprasellar extension. Postoperatively, they looked at visual acuity and field defects. Generally, the goal is to stop the progression of vision loss, and they saw significant improvements in many, though the paper notes that GPAs are associated with more complications than smaller adenomas.
Let's talk about those complications. This is the part of the paper every practicing surgeon will flip to first.
The numbers reflect the high-stakes nature of these cases. Serious complications like tumor apoplexy occurred in 5.9% of patients. Meningitis was seen in 3.5% and CSF leaks in 2.8%. They also reported on cranial nerve palsies and loss of vision.
And mortality?
7 deaths occurred in the early postoperative period, which is a 2.4% mortality rate. For standard microadenomas, we expect near zero mortality, but for giant tumors that distort the hypothalamus and major vessels, 2.4% is a reality we have to discuss with patients during consent. One thing I found interesting in the material and methods was their endocrine assessment. They've been doing this so long that they noted reliable IGF-1 measurements, which are crucial for acromegaly, have only been possible in their center since 2013. It really shows the evolution of the field over the 40-year study period.
It's a good reminder of how far we've come. Now let's talk about the long term. Pituitary surgery isn't just about the first 30 days. What was the follow-up like?
The median follow-up was 76 months, over 6 years. At that point, 70.2% of patients showed a stable condition without requiring further treatment. That is a very important number for residents to memorize. Even if you only get an 18% GTR rate, you can achieve long-term stability in 70% of patients through surgery and presumably adjuvant therapies like radiation or medical management.
That's the personalized multimodal treatment the authors mention. It's not just the surgeon, it's the cooperation with endocrinologists, radiation oncologists, and pathologists. This is especially true for prolactinomas. The paper mentions that preoperative medical treatment was mainly used for prolactinomas and some acromegaly patients.
Dr. Aris, based on your experience, the paper mentions that the transsphenoidal approach was the primary workhorse even for these giants. Does that match what you've seen in the transition from microsurgical to endoscopic techniques?
Absolutely. While this series includes many microsurgical cases, given it starts in 1982, the trend toward TSS is clear. The authors mentioned that whether they used microsurgical or predominantly endoscopic techniques, the transsphenoidal route is often safer for the brain, even if you can't get the whole tumor. However, they are very clear. Individual patient and tumor characteristics must dictate the approach. If a tumor has a massive lateral extension into the temporal fossa, a transsphenoidal approach isn't going to reach that. You need the transcranial route.
They also mentioned tumor consistency. Some of these giants are soft and can be suctioned down into the sella from the suprasellar space, but if they are firm or fibrous, they won't descend. That's often when a second-stage transcranial surgery becomes necessary.
Exactly. The configuration of the tumor. If it's shaped like an hourglass with a tight constriction at the diaphragmatic opening, it's not going to fall. To summarize the conclusions of the study for our listeners, the treatment of giant pituitary adenomas remains a significant challenge. While TSS is the preferred route for many, the size and configuration often mandate a transcranial or combined approach, and that the 2.4% mortality and the complications like apoplexy and CSF leaks are significantly higher than in standard pituitary surgery. But with a specialized center and a multimodal approach, a 70% long-term stability rate is achievable.
It's a landmark institutional report. 289 patients over 40 years is a legacy of data. For the residents, I'd recommend looking at the full text for the specific breakdown of how they stage those 52 combined procedures. It's a masterclass in surgical planning.
Well said, Alara. This study from Erlangen reminds us that in neurosurgery, size matters, but strategy matters more.
That's all for today's episode. We hope this deep dive into giant pituitary adenomas helps you in your next clinic or case.
I'm Dr. Aris.
And I'm Dr. Alara.
We'll see you next time on the Neurosurgery Hub podcast.